Welcome everyone, one and all. Those of you joining us on Zoom from around Australia and some from overseas, and all of you here in person at the University of Melbourne, including Dr. Rickards, members of the Rickards family, and distinguished guests. At the outset, and on behalf of us all, I acknowledge the traditional custodians of the place in which we are gathered, their elders past and present, and thank them deeply for their grace in countenancing our presence here this evening. I thank their children and young people too, the inspiring example they provide to all of us of courage and creativity in the face of ongoing monumental challenge. I'm Susie Dean, and I greet you all on behalf of Mental Health for the Young and Their Families Victorian Group, known as MIFVIC, to the Winston S. Rickards Memorial Oration. It's my privilege to greet also Associate Professor Campbell Paul, who will deliver this, the 12th oration. Organised and funded by MIFVIC, the oration is supported by other groups with which Winston Rickards was closely linked. These are the Royal Children's Hospital Mental Health Service, the Mental Health Foundation Australia, the Faculty of Child and Adolescent Psychiatrists of the RANZCP, Emerging Minds Australia, and the RCH Centre for Community Child Health. We welcome all representatives and members of these organisations here tonight and thank them for their co-sponsorship. The oration is named for Winston Rickards, our founding president, whose interdisciplinary work in child and adolescent mental health was groundbreaking. Now, information about Winston's remarkable service is available from our outer desk. So we come to the oration. First, I will ask those present here to turn off your mobile phone for the length of the session. At its conclusion, after 60 minutes or so of Campbell presenting, I will also ask those present to turn off their mobile phone for the oration. Sorry, I will ask Dr. Alan Maudsley to respond and then welcome general discussion, including questions from our Zoom audience. President Professor Joe Grimwade will speak briefly about MIFVIC and conclude our event around at 9:30. And after a brief photo shoot out the front here, our orator will be available to speak personally with people here present in the foyer. Associate Professor Campbell Paul is a consultant infant, child, adolescent and family psychiatrist at the Royal Children's Hospital and the Royal Women's Hospital in Melbourne, and Honorary Principal Fellow in the Department of Psychiatry at the University of Melbourne. He has delivered postgraduate courses in infant and parent mental health, along with colleagues, Associate Professors Bridget Jordan and Frances Salo, since 1995. These courses developed out of a long-standing experience in paediatric consultation liaison psychiatry and infant parent psychotherapy. He has a special interest in understanding the inner world of a baby, particularly as it informs therapeutic work with infants and parents. Dr. Paul helped establish the first specific mental health services for Australian First Nations children in the Koori Kids Mental Health Network in Victoria. He is a member of the Australian Association of Group Psychotherapists, and with Dr. Frances Salo, set up a series of infant parent psychotherapy groups. He helped establish the Australian Training Centre for the Newborn Behavioural Observations at the Royal Women's Hospital in Melbourne. And he has been a member of the World Association for Infant Mental Health, that is WAME, for many years. He is now currently president of that World Association. Campbell, please.
Thank you very much. Thank you very much, Susie. And thank you immensely for the invitation to meet with you here this evening, honouring the work of Winston Rickards. It is a great honour to be able to do this. And I'd like to acknowledge and welcome the Rickards family, who are taking up most of the front row here, which is really very pleasing to see so many of Winston's family here tonight. Lots of very powerful and strong memories are flooding back to me. I'd like to thank the organisers, Mifik, Susie, Joe, Alan, and the committee, all of the committee for hosting, organising, initiating this very important event. It is indeed an honour to be talking here in this auditorium at Melbourne University about mental health work. And I'll talk particularly about work with infants and young children and their families, but beyond that as well. And to talk about the role that Dr. Winston Rickards had in the development of my professional activities, which is only one little glimmer of the impact that he had on the professional and personal lives of so many people. I'm speaking as the current orator out of a very distinguished list of previous Winston Rickards orators who've been giving presentations on critical issues facing children and adolescents, ranging from human rights, developments in clinical service delivery, the need for comprehensive mental health planning, and many other topics. I'll talk to some degree about my own personal experience in child and adolescent psychiatry, particularly the areas inspired by the work of Dr. Rickards. It seems to me crucial that child and adolescent mental health, from this field, we must devote an appropriate portion of our time and resources to giving voice to stressed and troubled infants and young children. We've so much to learn from babies, toddlers, if we give them the voice. They require access to good quality mental health assessment, therapeutic work. We know that the prevalence of mental health problems among the 0 to 4 or 0 to 5-year-old group is roughly similar to the diagnosable mental health problems of children up to the age of 18 and beyond. We have a system for classifying and diagnosing mental health problems, one of which the DC 0 to 3 classification system has been developed through the DC 0 to 5, developed through the DC 0 to 3 organisation out of the US in collaboration with mental health clinicians across the world. It remains extremely problematic, however, that we still have very few comprehensive epidemiological studies of children in these first years of life. We need to continue to develop diagnostic and classificatory systems and for relationship problem disorders as well. The Lausanne group, headed by Elisabeth Fivaz de Persinge and James McHale in the US, have been researching patterns of infant-family relationships for some years. It's very gratifying that this has led to further family-based interventions with infants and families, but there's a long, long way to go. Professor Frank Oberklade in the 11th Rickards Oration last year stressed the crucial importance of mental health policy reform on a statewide and national basis. We must be part of that. We had many inquiries, including the Royal Commission here into mental health services in Victoria, the Productivity Commission, the National Children's Mental Health and Wellbeing Strategy, and a number of other inquiries, including a really important one from Western Australia recently handed down. The need for reform and change and further investment in child and adolescent, including infant mental health, is clear. Collaboration across all disciplines and sectors of welfare and government is crucial for reform and for improved delivery of high-quality mental health services for many children who are suffering and going without the therapeutic help which is really needed. But back to Dr. Rickards for a moment. My interest in child psychiatry commenced when I was a medical student on placement from the Melbourne University Medical School at the Children's Hospital. Each group of students doing the psychiatry rotation spent time observing clinical work with troubled infants and families at the Children's. With my group of student colleagues, we observed Dr. Rickards meeting for treatment and assessment young children and their families behind a one-way screen. We heard a bit of the story before the session started before the arrival within the clinic. And then we watched Dr. Rickards and colleagues and children and parents behind a one-way screen on the fifth floor of the now demolished Old Royal Children's Hospital. There we sat, headphones on, a group of medical students, WSR or Dr. Rickards sitting low down on the floor with very young children at his feet, at his side, deep in play. Beforehand, we heard some of the story, why the child was in the clinic, what the parents' background was, what the development of the problem was. And then we were shown a selection of toys that emerged from the well-tended cupboards within the clinical room. I was deeply interested and moved by the connection that Dr. Rickards made with several sad and troubled young children whom we saw through this one-way screen. The children arrived sad, as I remember it, but were able to join with him in lively, interactive play. I returned later as a young registrar, fresh from general psychiatry training in Edinburgh, to the same department with Dr. Rickards as the head. The department at that stage was comprised of a number of disciplines: psychology, psychiatry, social work, psychotherapy, audiology, speech pathology. There was a strong interdisciplinary collaboration with thorough assessment and psychotherapy with the child and adolescent, and the creative, did I say psychotherapy? I did. The creative therapeutic work with the family. It's been a great privilege to have been able to train and work at the Children's Hospital Mental Health Service over the last, dare I say it, 42 years now. And I believe that it's been a very enriching experience for me personally, but I hope that my experience and training has been able to help the many children and families whom we've seen. I was one of a number of trainees in the child psychiatry program. Seminars were coordinated by Dr. John Dingle and Frank Bishop and contributed to by all of the staff, including a number of people here in this room tonight. I say that I trained at the Royal Children's Hospital, which is very much true, but I've received a very strong and international and diverse training. And I think that's one of the profound legacies of Dr. Rickards that continues to this day with the current management as well. Dr. Rickards and his colleagues who constituted the department when I arrived in 1980 were from a very broad range of disciplines and training. My experience was that at the centre of this work was a deep respect for the child and the adolescent patients and their families, but the child was at the centre. The inner experience of the child within the context of the family was the thing which we strove to understand, and their pain we strove to ameliorate. Dr. Rickards had a series of aphorisms which did help focus the thinking and attention at time. Some of these seemed enigmatic, but really quite important. One that comes to mind first is a child is a child is a child. And what I think Dr. Rickards was saying is that we need to think of childhood as a special period of life, that we need different tools to understand and meet and help children. And that's especially true when working with pre-verbal child, with babies, infants and toddlers. Our work, as it is now, involved a very broad understanding of the phenomenology of mental ill health, and we used a range of therapeutic methods. My clinical experience has been enriched very much by the dedicated and creative staff of each of the departments in the hospital. The department itself was a centre of excellence here. Particularly powerful was this key interweaving of disciplines, focusing on the child as an emerging and developing person within the family and the community. There was a strong psychodynamic understanding as well as psychometrics. It was a very strong speech, as I mentioned, audiology, psychotherapy for the deaf. The hospital provided an internal training program, which was a pioneering one and accredited by our Australian New Zealand College of Psychiatrists. Other colleagues like Bill Blomfield, George Christie, Frank Bishop and Pat Leeper I've mentioned, and a company here present provided this breadth of experience. The department fostered close ongoing links with centres of excellence in child and adolescent and family mental health in the UK, in USA, in Europe and throughout Asia. And as I say, my training was at the Children's, but it felt like it was and still does, a worldwide informed training. Strong links with the TAVI, the Tavistock Clinic, the Anna Freud Centre, Judge Baker Clinic, E.J. Anthony in Washington, University St. Louis, and visiting experts, of whom Dr. John Bowlby was a visiting scholar in the late 1970s, very late 1970s. I had some sabbatical leave, which was a great privilege, and worked with Lynn Murray at the Winnicott Research Unit in Cambridge, and was a visiting scholar at the TAVI while I had a weekly infant observation supervised by Iska Wittenberg. I sat in on seminars with some of the key people in the UK infant mental health movement, Dilla Storrs, Juliet Hopkins, who remain closely connected with us even to this day. And similarly with colleagues in Paris, Antoine Guédonnet, and was able to sit in on the Diplôme Bébologie at the University of Paris, Bobigny, led by Professor Serge Lebovici. So we had access to the world, even though it took a day to get there. There were great riches within the mental health service itself, with pioneers in terms of people working in child and adolescent psychiatry, classification, psychopathology, psychotherapy, clinical child psychology. We had and still have a strong interest in family therapy, George Christie, Peter Burleson, Bill Blomfield, Maria McCarthy. So it was a very rich experience for me. And it allowed me, with the support of the subsequent directors, Bob Adler, Peter Burleson, Rick Haslam, to foster an interest in infant mental health. In the midst of these exciting clinicians and researchers was a particularly important colleague, Dr. Anne Morgan, who grew up in Wales, was a paediatrician, trained in London, Dublin and the US, and came to work at the Children's as a paediatrician, but was especially interested in young children with developmental problems. This transformed into her interest in mental health and psychiatry, and she became a member of the psychiatry department as a paediatrician and a passionate psychotherapist and group psychotherapist. And Anne was one of the key people who fostered this interest in babies. How can we look through the baby's eyes and understand what the sick toddler in hospital might be experiencing? She was very passionate about that, and passionate about the baby within the family. More anon about that. True to the overall philosophy of our department, the infant mental health service evolved very much as a cross-disciplinary one, linking maternal and child health, Sister Michelle Meehan, paediatrics, Dr. Peter Hewson, and many others. Peter was a talented general paediatrician and researcher with whom we worked very closely. Susie Tarian from within the department, Sue Morse, the late Sue Morse, was a very powerful influence on the development of work with infants and young children. At the foundation of the work from every one of these clinicians was a deep respect for the child and for the child's capacity to play. Winnicott has been one of the key theoreticians whose work has underpinned our approach. He was very focused on, again, understanding the child, the infant-parent relationship. Play, as the basis of our work, is like the royal road to the inner world of the child, if I can paraphrase another person, especially when the child is stressed and perturbed. In my talk this evening, I'd like to explore some of the importance of play and work with especially young children, but with babies and toddlers. Respectful engagement has been a key part of our work with many gender diverse children and adolescents with whom I've had the honour to meet and work over these last 15 years. So gender diversity, gender dysphoria, as it was called, is something that the department was very much involved in providing, I think, a very strong and professional service for. So there's clear evidence that infants and very young children in the 0 to 5, 0 to 6 age group suffer from serious mental health and relationship distress and meet criteria for a range of mental health disorders which can be described and classified. And this capacity to classify and understand helps us understand what we're dealing with, how we can identify and help young children and their parents. Parents are generally relieved when we reach out and make a direct interpersonal connection with their young infant or child. When parents see their baby looking, listening, reaching out, imitating, copying, playfully engaging, I believe there's a general sense of relief for parents who are troubled. And we'll talk about this when we come to talk about play. I'll talk about the important human capacity, if I can paraphrase a poet, Robert Burns, capacity for seeing ourselves as others see us, this capacity for intersubjectivity, for being able to put ourselves in the shoes of others. We might think this is something that's acquired later in childhood, but I hope to show that it's something that is there from the beginning. So I'm going to switch over at this point to some PowerPoint presentations, if I could do that. Well, actually, I'll just move forward. You might recognise the tapestry photograph there, which is by Robert Igpen and the Victorian Tapestry workshop in the main foyer in Main Street at the Children's Hospital. And it's after Bruegel, I suppose, Children and Play. I'd like to acknowledge country, that we're on the lands of the Wurundjeri people of the Kulin Nation, as Susie has already mentioned. But we are indebted to the First Nations people who have 60,000 years of culture and approach to care for children and infants, and all community, and warmly welcome First Nations colleagues who might be here today who work with us. And also to acknowledge people with lived experience of mental ill health and recovery, and the experience of people who are supporters and carers. And I know that MIFIC is a very powerful advocate for carers and supporters, as well as young people with significant mental health problems. This is a bit of a plan, and as I've already indicated, I'm going to talk as much as I can about play and the importance of that in our work with infants. Just to come back to acknowledgement of country, also to acknowledge the devastation that occupation of this land has had on many First Nations families, and the consequences of intergenerational trauma are with us today. Although Aboriginal people First Nations people comprise 2.8% of population, they, and a smaller percentage, though growing and very healthy in Melbourne, they do represent over 10 times more of the children who are taken into care in childhood. So we really need to support and work with First Nations families and professionals and organisations. We need to learn as well, and the phenomenon of storytelling, of nduttery, of deep listening beyond the words, which is what infants and young children do. But it's an integral part of much of First Nations culture, and from which we can learn a lot. I'm privileged to be able to be working with Professor Kath Chamberlain, who's here at Melbourne University, and leads a number of research projects under the heading of Healing the Past by Nurturing the Future. So again, there's an important role for child and adolescent mental health to work with our colleagues in a collaborative, creative way that does make a difference. So coming to the baby, what does the baby see when they look in the eyes of the other? Do they see themselves reflected, or is there, as might seem on the left-hand side of the screen, a bit of an emptiness, a sadness? These are two small sculptures in the Met Gallery in New York, both from France, and you can see a remarkable difference in the mood of the protagonists here. There'll be lots of reasons for that, doctrinal and artistic, but I really like the image on the right where the baby Jesus is tickling his mother's chin. It's not something you see so often in these depictions. So to turn to a young girl I've called Flora, the girl in black. I'm not going to talk to you. Well, she didn't actually say that. She didn't say anything, which was the reason for referral to mental health. She was a girl who at age 2 had a diagnosis of frontal neuroblastoma, which was successfully treated at the time. But at age 6, there was a recurrence of a tumour, which was going to be successfully treated, but it was really, is that me too close to the mic? Yeah. Successfully treated by chemotherapy. But this was a complex and intrusive process with lots of blood tests and treatment, intravenous treatments. It got so distressing for her that she, when she appeared at the clinic, she would refuse to speak. She wouldn't talk to the oncologist, wouldn't talk to the nurse, she wouldn't talk to her parents. She was just mute and angry. And it was becoming difficult to help her be engaged in her treatment. So they referred her to our mental health service as she seemed sad, angry, distressed. But she was a young girl who could make a good statement. She always dressed in black when she came to the hospital. So I was meeting with her for the first time in a clinic room. Not the same as the old hospital. We share them with other staff, so it's hard to have the same approach to toys and our necessary equipment, but we get by. And sometimes you have to compromise and use what's there. So here we were in the room together. She was refusing to speak, but I was sort of getting a little bit somewhere. School, grunt, no, turn away. School camp, yeah. Where did you go? Farm. Oh, there are cows or goats there. And then silence. And then I saw the gloves in the box above the sink. And I took out one of these gloves and blew it up. Oh. And the mind of a psychiatrist says, well, you know, maybe this could look a bit like a breast or a cow's breast anyway. There's an udder with some teats on it, although I didn't say that. That was just going on in my head. But we talked then a little bit about it, and I blew it up, and then unfortunately I let it go. I didn't mean to, honestly, truly, and it flew straight at her face. And I was shocked and horrified. What sort of professionalism is that? And I breathed in deeply, covered my heart for protection, I suppose, and said, oh, sorry about that. She looked back at me and then she started to laugh. She giggled, giggled and giggled. And then we started talking. And she started drawing silently at first, and then she explained what she did. And she did an Escher-like staircase with blood dripping down it, And then in another picture, a big steel cage with locks on it, and a person inside again with blood coming out. And we were able to talk about, is that a bit like what it's like when you have to come here? And we were able to go further and further into the therapy. What happened then? I think in the context of the therapeutic relationship that wasn't there, but developed very quickly, I think there was a shift, a risky bit of impingement by the therapist, using impingement in a Winnicottian sense, if you like, and teasing play was initiated. I didn't know where it was exactly going to go, but it led to us making a powerful connection. And I think for Flora, what happened was she was present in the room, and she was reluctantly there, but I think she was saying, I'd like you to know how I feel, because I think I might have an idea, and only you can help me if you want, and you can risk trusting me. And I think my response with the accident in the session, and the response to that was a message that thought she was entitled to experience rage and hate and distrust. There was a non-verbal interpretation that emerged during the session in that moment, and there was a capacity then to draw a more playful and perhaps ongoing transferent sort of relationship. She went on to do a lot more drawing in subsequent sessions, and although there were other issues within the family, difficulties, and she was able to wear different colours to the hospital and to talk and be more participatory in her care. I think what we saw then was a therapeutic moment of meeting. And this is drawing on the work of the Boston Change Process Study Group, led by Lucinda, the late Lucinda, Dan Stern, the late Dan Stern, and others, Ed Tronick, where they were looking at what are the crucial things that lead to change in therapy. Their work, I think, is really good reading. But they talk about moments of meeting where participants interact in a way that creates an implicit intersubjective understanding. There's an implicit feeling or experience that you can read the thoughts and ideas. You've got some idea what the other person is thinking, and vice versa. And that when those moments happen, you have a new way of being with the other, and it allows you to explore further from there. They say it's created on the spot, comes from the therapist's own sensibilities and experience. It's beyond technique and theory, a bit of a challenging statement. And it follows an open space, a space where this intersubjectivity can play out. But I think it also needs playfulness. And here we're talking about work with infants and very young children, but I think it's very applicable to work with adults, which is where a large part of the Boston group discussions came from. We have these transformational moments that happen in the present. And as I say, it builds on this notion, the experience of intersubjectivity. Play allows us to go into areas where we might not otherwise be able to go. You'll have known the book by Maurice Sendak, Where the Wild Things Are, and the second image there is from another of his many books, The Night Kitchen, which address, I think, in a way that is palatable and manageable and useful, issues such as violence and anger and resentment of parents and hatred of parents, in a way that children can move forward in bite-sized pieces. It also addresses the issue of sexuality, which is a taboo one very much in very many centres nowadays. But in The Night Kitchen, Mickey, the hero, smells beautiful bakery smells from the baker's place outside his house, his unit in apartment in New York, and he jumps out of the apartment goes to the bakery, becomes encrusted with dough and becomes a plane and flies around and finishes up down into the bottle of milk, and naked. Horrified US librarians, as you could imagine, and was banned for quite a while, but it's a really lovely book. Yeah. So I've mentioned about the early beginnings of, well, from my point of view, the beginnings go back, of course, way beyond my arrival, and the links with colleagues both locally and overseas. And within the Children's Hospital, there was a real support and encouragement for work with infants and very young children. And we're privileged there because the children that we work with are often there for a period of time with a chronic illness or repeated admissions. So in a sense, we've got a bit of a captive audience, although increasingly, of course, young children, infants and families are having psychotherapy in the community as well, which is another part of our service. I was also privileged to work with Alan Maudsley and the Alfred CAMS infant mental health team when Alan was such a strong advocate with Anne Morgan and others in setting up the infant program at the Alfred. And I've already mentioned the Winnicott Research Centre. The key thing that I found really fascinating there was, well, a lot of the research that Lynn Murray was doing and still has a finger in the pie, but very creative researcher. One of the assessments she did was to have the children whose parents may or may not have had, mother may or not have had a depressive illness in the perinatal period, and now they're coming at this time, this is years ago, coming to the research unit at age 6 and 7, and she had a doll's house and took the back of it and put the doll's house against the one-way mirror and set up a few scenarios, a bit like other people have done subsequently with a story stem, and was able to observe and record what the children were doing through direct watching, but not while they're in the room. Lynn is very creative. But she also had Kevin Nugent from Boston, who was still is at the Brazelton Centre, to come and train two of us in the newborn behavioural assessment scale. And that's led to us developing the newborn behaviour observation since then. And Morgan was very interested in that as well. And the newborn behaviour observation is a way of meeting infants in the first 3 months of life and sharing what they can do with their parents. Here's Anne Morgan at the end of a teaching session for the former graduate diploma in infant mental health, and talking about the importance of engaging the baby and working with the baby in the presence of the parents, how important it was for the infant to see themselves as part of a triad, part of a group, and being able to be outside and watching an interaction between other parents, between the parents or a parent and another, in a way that's safe and contained and therapeutic. And it allows the baby to be held in the mind of the parent, of the mother, especially in a different way as well, when the therapist is able to support and orchestrate this triad or quad. So with encouragement from the directors of our departments, from Bob Adler and Winston before that, we set up a diploma in infant mental health, which is continuing now through Mindful, and with the support of Paul Robertson, who's here tonight, as the infant mental health advanced training. We do 2-day, now twice a year, training in infant mental health and introduction for 2 full days, and have just done another one with over 200 participants in that. And there are lots of other trainings going on in the state. The child parent psychotherapy, which has devolved from Selma Freiberg, Alicia Lieberman, and the group at Tulane, is training a number of people as well. So there's quite a bit of activity in training. And it means that we're able to meet the baby, toddlers, preschoolers, in active therapeutic ways in a range of settings. The baby brings hope, but there's a paradox, if you like. It gives us hope about the future, but we also have to accept that the baby has a mind, and what happens if the baby's experience, the baby's mind is perturbed? Can we cause damage? Can parents cause damage to their baby's emotional development, social development, cognitive development? So acknowledging what babies can do has its consequences, which I think are very appropriate, but it means that there can be pushback against that, not infrequently. Don't be silly. Babies can't think. We know that, but Piaget didn't really have us seeing babies as thinking cognitive persons from the very beginning. That was something that had to be developed by experience. But we know now that babies don't arrive with a PhD, that's true. They can't write a thesis, but they can read emotional expression, they can read behaviour to save their lives, if you like, and to enjoy their lives. So how do we connect with infants and young children? We use ourselves, we use toys, we use gaze, voice, touch, spoken word, occasionally physical holding. I think that's where the newborn behavioural observation is really very helpful. It gives us a structured way of meeting the baby through touch, gaze, through observing and interacting with the baby with a rattle, with a torch, and with physical handling. And I think we need to do this because this is the language of the baby and of young children, is a physical language, not just words. We have to take risks. So picking up a baby is a risk. You might drop the baby. Never have, but it happens. The baby might wriggle. The baby might spew on you. The parents might feel, hang on, what are you doing handling my baby? And you need to be able to think and address and work with those risks, if you like. Tronick's statement about the importance of rupture and repair, that sounds a bit dramatic, that we don't actually rupture anyone, but disturbances in the interaction are part of the process of growth and development, the process of repair. People think, oh, you need to look at babies and smile at them all the time. Well, that's rubbish. A breastfeeding mother will look at her baby maybe 5–10% of the time, and some will do more and some less. Parents don't need to believe they have to be focused looking at their baby all the time. Baby needs a space for their own development as well. And I talk about the seriousness of playfulness. It's really important that we are able to play and play seriously. Here's a little girl called Chrissy, and her family very happy for us to use the story and video, who was referred to us after being hospitalised a number of times with a complex cardiac disorder. She needed a number of surgeries, had a lung removed. And then prior to the referral, her parents noticed in the previous months she became increasingly distressed and disorganised whenever she came to the hospital. She was having difficulty sleeping at home, anxious and agitated. From the mum's description and her hospital team, it sounded like she met criteria for a significant post-traumatic stress disorder.
Kiss.
Here's her little.
There's Humpty sitting up there. Oh,
Uh-oh.
he fell down.
Yeah, is he alive?
Upside down.
Okay. Have
Up
another
you
go.
Humpty. Uh-oh, poor Humpty. Poor Humpty. There he is. Ah,
Bear is the cuddly
Fell
toy.
down.
Now what's
Humpty
happened?
go. Up you get. Humpty.
Resurrection.
Down you go.
Death.
There's the
Bear.
bear.
Oh, hang on. That's your cuddly one.
No, there's the duck. What does the duck say?
So here she's really
Quack, quack.
heavily to play.
What's that? Oh, here's the phone. Hello? Hello?
She's only seen mobile phones, but she knows what this one is. Hello? Okay. And then we progress in the session, and we have the medical toys. So she starts to play with these, and I offer a few things, and she puts some down. She notices the little toy X-ray and looks at that up at the light as if she's been in the radiology department many times. I'm sure she hasn't. And she notices that the little doll's got a sphygmomanometer on her arm, and she gets quite distressed. You can see her looking, and she says, "Off, off," and she reaches for it, "Off." And I say, "Do you want to squish the bulb?" "No, off, off." Eventually we take the sphygmo off. But as she does that, she grasps her own forearm and squeezes quite hard and looks up at her mother, who's the one holding the iPhone camera. And I think what she was telling us there was this was a replay of her painful experience, but it was a somatic experience she had as well. So her psyche soma was busy at work. Her mother was very sensitive and attuned woman, but very traumatized too. And I said, "Have you got a doctor's kit at home, a medical kit?" "No, I don't. Maybe we could, maybe we should." And she did. And she said straight away, Chrissy became the doctor. Her baby brother was being examined uphill and down Dale. The anxiety that she had about hospital and hospital visits dropped dramatically, as did the mother's anxiety. Her dad found it a bit harder, and I think we didn't really engage well with him. But Chrissy and her mum and her little baby brother were able to move forward, and the diagnosis of PTSD was able to be left behind as well, which incidentally is a big problem for infant mental health. Not infrequently the symptoms that children have at a very young age, when we've got opportunity to intervene, are transient. And so our adult colleagues would say, well, it can't have been a mental health problem if it went away, because our mental health problems don't largely go away. So it is an issue for us in infant mental health. I don't need to go through this, but just to say that what we saw, I think, enacted in there was her experience of a somatic memory, procedural body memory. She was moving towards, but not quite there, a stronger capacity for being able to declare and put into words some of her experience. Of course, there's only two forms of a whole series of different types of memory. I mentioned intersubjectivity, and very informed by the work of Colwyn Trevarthen, biologist, researcher, psychologist in Edinburgh, who talks about the levels of intersubjectivity, and he and philosophers and other psychologists, but Colwyn promulgates this concept very clearly, I think, that we're all born with rudiments of individual consciousness and intentionality. We've got subjectivity from birth. Maybe, yes, I think so. The infant can fit and adapt this subjective control to the subjectivity of others. So you have a relationship. And it's transmitted not through magic or ether or the unconscious group work. Well, that's another story. But through gaze, through touch, through voice, through hand movements. Primary intersubjectivity, that we can demonstrate the baby has an awareness of another person being there at this point he was saying at least 2 months of age, but I think it goes much earlier. And it's later that we see that, say with the Rouge experiment at 18 months, where you can show that the baby can show us that they've aware that the person in the mirror is themselves. That's a demonstration. It doesn't mean that before that age, that capacity is not there. That makes sense. So he says infants have expressive, creative mimesis, remembering from the beginning, capacity to express internal experiences in their memory. And this is done through the baby's use of body, gaze, movement of limbs, vocalization, and other modalities. He and his colleagues, Jonathan Delafield-Butt, who was working in the phys ed department at Edinburgh University with swimmers and looking at their stroke, became entranced by the work that Trevarthen was doing. And what they did was to do something similar to the swimmers, but in the neonatal nursery in Edinburgh, where they put markers on babies' limbs and the mother, and videoed and looked at really great detail about the balletic synchrony that works between infant and parent, even the premature and sick babies. And he says that a good human mother is more than a protector of the infant from fear, and more than a known and secure base from which the infant may explore and gain experience. She, the infant, like others with whom the infant may know and like, is a friend. Sorry, the mother is, like others the infant may know and like, is a friend and a playmate, as well as all the other things. So he's saying there's more to existence than the more narrow interpretation of attachment and attachment theory. There's more to it than that. And this capacity for intersubjectivity and play and playfulness is clearly important. His colleague, MC Naj, who works in Dundee and in Prague, has done a lot of research with newborn babies and older and younger, premature babies as well, with their capacity for imitation and social engagement. So in this experiment, she's talking to a baby who's comfortably seated in a chair in the first week or so of life, and she's having a social engagement. Oh, how are you going? What's going on? And moving her head a little bit, her eyes, her gaze, talking, and the baby's becoming engaged and entrenched. And then she stops and says nothing and doesn't respond. And the baby gets quite distressed. You've seen the Edtronic video, I'm sure, of the still face experiment with 12 months and older kids. Here it is in the newborn as well. And she's able to demonstrate of the newborn imitating. She has a social experience, she stops talking, and then she holds up a finger. The baby thinks, what's going on here? And the baby holds up a finger, as if to say, what happened to the game we were playing? Can't you keep that going? And the baby, even at this age, imitates one finger, two finger, and makes a C much more frequently than by chance alone. Vasu Reddy, one of Trevarthen's colleagues, has taken a different approach to psychological understanding of young children, and rather than being strictly laboratory based, she uses the social context to try and understand what the infant is thinking and feeling, and has demonstrated that there's a theory of mind for babies way before the age of 2, in that they're able to think about what the other person's thoughts and feelings and intentions may be and demonstrate that to us. This is really important, I think, in our work with young children, but also with older children and adults. We, I think, underestimate the importance of non-verbal and subtle communications with all of the age groups with whom we work. She demonstrates that even under 9 months, babies are able to do teasing. Maybe too often, but not infrequently. I'll offer a child a little block. They'll reach for it and I'll pull it away. What's happened? And then offer it back again. And then on the third time, I usually hand it back to them. But the child realises that this is a game. If the child shows no interest in the game, there's a worry, there's a concern. We've got a bit of mental state examination under our belt. So we can learn a lot through play. And we know that babies can imitate what we're trying to do. They can also disrupt our intentions. A little girl I've mentioned here was actually 18-month-old, had cardiac surgery, 4 episodes, in and out of hospital, slow recovery, and she was getting very distressed at night. Her mother was staying in with her, but when she went to go to sleep, she became distressed. And what she developed was a game with her mother. Her mother would go to sleep. She was awake and a bit distressed, so she'd vocalise. And then her mother would stir and she'd spit the dummy out and the dummy would land on the floor. Her mother would have to get up, come over, pick the dummy up, clean it and put it back in her mouth. She'd go and sit down on the couch trying to go to sleep, but she'd do it again and she'd do it again and she'd do it again. And then with a little wry smile, her mother would come back and then she'd fall asleep for a few hours. And then when she woke up, she'd do the same. And the mother would have to come over. So she invented a game of her own that drew her mother closer to her in an area where she felt very, very frightened, teasing and playing in the service of survival. So this is just referring back to Ed Tronick and the development of affect regulation, and also bringing in the work of Honegger and colleagues about mirroring and marked mirroring. Not much mirroring here, the National Gallery of Victoria, from a good example of, well, feeding. Now, how am I going for time, Susie? I've got it written down somewhere. And I'm going to finish up at... I could, okay. Yeah, that seems too generous. But anyway, here we go. Yeah, that's right. Here's a boy who was really very perturbing to meet. I've called him Harry. His parents, his mum was very happy for us to share his story and some of the images. But he had just turned 4 months. And his mum had only been to the infant welfare centre, the maternal and child health nurse, on one occasion. She had 2 older children and things had gone well. She'd breastfed each of them and they'd grown okay. So she wasn't perturbed, but when she walked into the maternal and child health nurse office, the nurse was horrified and said she had to immediately go to the GP. And the GP immediately sent them to hospital at the Children's. He was born normal delivery, 41 weeks. It was a benign renal cyst, but of no particular consequence. And there you can see his growth chart. That's my reproduction of it, but he started off on the 75th centile, thereabouts, or in between. And when he came to hospital, he was on the 0.01 centile. So he'd lost dramatically, although he was feeding at the breast, she thought, well and regularly. But he was at the breast, but not feeding. There were lots of investigations done. Did he have a tumour or a cancer or pneumonia, or nothing turned up in any of his medical examinations and assessments. And we saw a very flat, empty, sad little boy. This is again a picture of the in figures of his weight, so that he was actually just a few grams above his birth weight at 4 months. Thin, cachectic, holding him was very unnerving because you could feel all of his ribs. So the diagnosis was of malnutrition, maybe kwashiorkor, because he was very flat and depressed as well. He met criteria for infant depression, although actually DC 0 to 5, it's not a strength for that in very young children. So he doesn't actually meet full criteria for depression with DC 0 to 5, but clinically he did. If you go back to the work of George Engel and co in Rochester, New York, where they termed infant withdrawal syndrome, conservation withdrawal syndrome. Harry met those criteria for a similar diagnosis. His mum was distressed at being in hospital. She had to share a room through a joint bathroom with another family and was feeling impinged upon, but she stayed, and with him we did quite a bit of work. I'll just go back. One of the things we did, the key thing that was helpful for me anyway, and I hope for him and his mum, was to use the newborn behaviour observation. So he's a still of the action of the newborn behaviour observation. What I'm doing here is offering him an opportunity to sit up. So can we sit up? I hold his hands gently, my fingers behind his head, and just pull him to a seated position. And with a newborn baby, so we'll do that with a baby on day 1 or day 2. And you'll see the baby's capacity to maybe hold their head up a little bit and then it drops down, but they'll be looking at you. A baby his age, a child his age, should be able to have quite good tone and hold his neck up for a good while, which is actually what he did. And when he did that, he looked straight at me and held my gaze. And then I say, has he been on his tummy? How does he like? I'll turn him over on his tummy. And as I do that, he glances at his mother and then looks down at the cot, looks back up at her, and then quickly turns away and looks at the toucan there. Later, his mum says, he seems to prefer the toucan to me. And quite a poignant moment, because that was the observation that we had, that he avoided gaze with his mum. But with the nurses, who were very perturbed by him, they said he had and Sophie Oldfield up here worked very closely with his family and with the nursing team as well. The nurses were very perturbed by his blank gaze and avoidance of gaze. But through the NBO and through trying to be attuned with him, we're able to join him in play, and his mother, over the first 3, 4, 5 days, there was very little engagement with his mum, but step by step, she was able to recognise something that's gone wrong here, and worked to really very creatively to rejoin with him. And here we're talking about, I say, what do you think's going on in his mind? And his mum says, I don't know, he's got the smallest voice out of our 3 children. and she meant he was the littlest, but I think she really did mean he doesn't have a voice in the family. There was a realization. I say, well, he's got a strong voice now. It's because he was actually at this point. He was vocalizing in this context. I say, you've got a lot to say now. What do you think? What do you reckon? And his mother could see that he had that capacity. And over the course of his hospitalisation, which nearly was around 2 weeks thereabouts, he started to feed again with the bottle from the nurses and then from his mum. And I don't think she continued breastfeeding from memory, but he continued to grow. She said in retrospect, yeah, it was a good baby. He never cried for anything. He didn't even cry if he was hungry. He seemed a very good baby. And she then talked about her own experience of growing up as a childhood, very lonely. Her parents moved frequently as part of her father's job, and how isolated socially they were in the community where they were, in a semi-rural area. Husband working shifts, but she was a good woman who was working in her own job and caring for her children, not working since Harry was born. She was able to talk quite a bit about growing up, becoming a mother again, and the third time, and the sadness and isolation that she'd experienced. So she was talking to the ghosts that had been there in her own past and able to bring them into the present, and then find a different relationship with her husband in the course of that therapy as well. And then, as you see, his growth resumed towards a normal trajectory. When we met up the last time after this, when he was about 12 months, she said she's not going back to the previous job, but she's going to be a midwife, and she wants parents to know more about infants before they're born rather than just what happens in labour. So she got a mission. One of the tools we used in this was the ADBB. It's a scale, an observational scale, a bit like, if you like, the Edinburgh postnatal depression scale, but a scale for getting a measurement of infant withdrawal, infant depression, from a colleague in Paris, Antoine Guédenay. He'd worked with paediatricians and puericulturists, so the maternal and child health nurses, and they said they got sick of him talking about depressed babies and babies that they should be worried about. And they said, well, it's all very well for you. You know what you're doing, but how do we know who to worry about? Haven't you got a way of sharing that with us? And he came up with this 8-item scale, an observational scale that's valid for 2 months, I think, for even newborn babies as well, but 2 months through to age 3 up to 4. And there's a 5-point scale for each of the items, ranging from observation of facial expression, quality of eye contact, general level of activity, self-stimulation. Babies who are there, you'll have seen Spitz black and white film where babies in orphanages are just there rocking. And they certainly meet criteria for this concept of conservation withdrawal, infant depression. So we're able to quantify this, and the cutoff for a clinical of concern is around 5 or 6, depending on the context. It doesn't tell you whether there's a brain tumour there. You need to be able to do your general health assessment of infants as well. But there might be a brain tumour and a depressed baby. So anyway. So what about the mirror role of the mother? I think with Harry, his mum was there, but not present in a lively sense of being present with him in the feeding context and in the playing context at home. so that when he looked to her face before he came into hospital, he did not see a lively self of himself reflected in her. As Winnicott said, what does the baby see when he looks into his mother's face? He sees himself. The expression on the mother's face, it could be the father's face, reflects what she sees in her baby. When the mother is depressed, her face is a mirror to be looked at, not into. And it's not just facial expression, it's Dana Shah, a colleague in London and Tel Aviv, has developed a tool for measuring the bodily expression of communication, not just gaze and voice. So it's how the baby and parent, toddler and parent communicate with hands, with posture, with voice, as well as gaze. But it also applies to us. What does the child see when they come to see us if we're not alive and playful? They see someone who's also absent. So the therapist has to be aware of the possibility of creating these important moments of connection, now moments. You need to be available so that you can reflect the liveliness that is there, the initiative that might be emerging from the patient. As Winnicott said about play, I put a lot more store on playing. If a child is playing, there's room for a symptom or two. And I think that's true. A symptom towards recovery, a symptom as an expression of a problem which can be solved, I think is what he was getting at. What's some of the characteristics of play? He's written a lot about this, of course. Play involves preoccupation. It implies a trust in the environment. It should be essentially satisfying, exciting, and precarious, a little bit dangerous. Children make friends and enemies in play. And play is really informed, I think, by his very creative concept of the transitional space, that space in between reality and fantasy is one way of very clumsy way of putting it. When he's talking about psychotherapy, he says psychotherapy takes place in the overlap of two areas of playing, that of the patient and that of the therapist. Where playing is not possible, then the work is done by the therapist, directed towards bringing the patient from a state of not being able to play into a state of being able to play. And here he was talking primarily about his adult work, but informed and very relevant, of course, to infants. So as therapists, we need to be able to, as doctors, as nurses, as psychologists, we need to be able to play. And Dr. Rickards was certainly a playful character in his work with children and families and colleagues, maybe. The therapist builds through play, maybe even using a bit of teasing. And this gets a bit of controversy sometimes. Are you allowed to tease with a child? I think so. I think if sensitive, attuned teasing is happening, you've started from the position that you assume the other person knows what's going on. And if they don't, if teasing a gentle, oh, what was that? Oh, no, you can't. Oh, okay, let's play. If the child's not able to enter into that quality of play, then you know there's a problem to work on. Because it can be done well. It's something that leads to respectful engagement. And it helps the child feel that they can do the same. They can be cheeky, as Flora was after the rubber glove event. She was able to be very cheeky. So, and I'm sure, well, Dr. Rickards certainly encouraged this playfulness in therapists. I mentioned the newborn behavioural observation, which is a tool for meeting with babies in the first 3 months of life and sharing their interests, their skills, their capacities, their capacity for play with parents. There are 18 items and 13 of those are actual physical engagement with the baby. And what we're trying to do, one of the things is to build a positive development for parents with the baby. And here, Kevin Nugent has coined the term amour, which we use to describe the baby's status. For the baby, it stands for autonomic system, motor system, organisation, and responsiveness. So, but in the adult, we are wanting parents to arrive at a state of affect regulation, to focus their experience and feelings on the other, not to be overwhelmed by anger or distress that might have come from something else, to be able to regulate their own affect, to mentalise, to think about what their child might be thinking and experience, and so to be open to the baby who's there, open to the real baby who's communicating and connecting. And in that context, you have reciprocity between infant and parent, which can lead to change. This is it represented diagrammatically. Affect regulation, mentalising, openness, and similar process happening from the baby. And we need, as therapists, as clinicians, something similar ourselves. We need to put ourselves into an affectly regulated state so we can think about what's going on in the mind of the other, be open to what they've got to tell us, and be responsive. I mentioned at the beginning about the need for more funding and more resources and more programs, and I'm not going to be able to address the range of things involved there, but this is just to mention a couple of things that we've been involved with at the Children's and at the Women's Hospital. Studies looking at premature babies, and the UNA study is women with a depression and anxiety in the perinatal period, where we're using the NBO as a key intervention. Okay. And this just to say that the NBO does build on the awareness of intersubjectivity for infant and parent. We saw 74 omnivorous women with anxiety, distress, or symptoms in the past of mental illness, and showed that NBO led to a positive effect with reduced anxiety and increased maternal emotional availability. So putting all this together within the context at the Children's Hospital, where we're working with very sick infants, we're providing infant psychotherapy, infant parent work, but with the focus on trying to enter the world of the baby, not just, okay, we fix the parents and the problem will go away. We need to give the baby, the child, the young person, the adolescent, the pride of place in our engagement, if you like. We need to ensure that we include the whole family, so that if we're going on a bear hunt, we're all in it all together. We're going on a bear hunt, we're going to catch a big one. I'm not scared. Well, they go through the tall grass and one thing and another, finish up in the cave. And of course, one shiny wet nose, two furry ears, two big goggly eyes. It's a bear. Later on, when they get home, we're not going on a bear hunt again. But it was a positive learning experience. And there's lots of learning you can do if you're interested in coming to Dublin, where our next World Infant Mental Health Congress will be held. And coming up next month on the 23rd of April is World Infant, Child and Adolescent Mental Health Day, where there will be some webinars and other activities for you. Okay, and that's your lot. If I can get out of this, there we go.
Thank you very much, Campbell. I know people will want to ask questions or comment, but first of all, let me introduce Dr. Alan Maudsley to respond to your excellent oration. Dr. Alan Maudsley, known to many here, Dr. Maudsley OAM, is a retired child and adolescent psychiatrist a member of the MIFIC committee and a previous orator of the Winston Rickards Memorial Oration. In his former professional career as director of the Alfred Child and Adolescent Mental Health Service, to which Campbell referred during his talk, he was a colleague of Winston Rickards and also of tonight's orator, Campbell Paul. As such, he is very well placed to respond to the important issues raised in the oration and perhaps to give some indication of advocacy implications for MIFIC's future lobbying. Alan.
Well, it's a rare privilege for me to respond to Professor Campbell Paul's masterly oration because I've known Winston Rickards and Campbell Paul for a very long time. I first encountered Winston in the 1960s when I was a general psychiatry trainee. When I returned from postgraduate child psychiatry training in Canada in 1971, I became actively involved in the section of child psychiatry of the college, which was one of Winston's important preoccupations. It was not long before I joined his planning committee for the 1978 Melbourne Congress of the International Association for Child and Adolescent Psychiatry and Allied Professions, another of his preoccupations. And this had me actively involved with the multidisciplinary staffing of his department at the Royal Children's Hospital, as well as undertaking a research project for a presentation at the Congress. Later, Winston joined the quarterly meeting of child psychiatrists that I chaired on behalf of the Health Department. He was initially the only member not from a government child mental health service. Other members were obliged to attend because of their employment. But Winston came because he believed in networking and collaboration, another of his preoccupations. Campbell Paul joined Winston's department and was imbued with these same influences. He became very involved in infant mental health, at that time an emerging specialty area. Not only involved, but a leader in the field, as we could see from tonight's presentation. The specialty of infant psychiatry is still sometimes difficult for the layperson to grasp. When I was interviewed for the Electoral College of the Alfred Hospital to become their first specialist child psychiatrist, a head of department position in the late 1970s, the first question was asked by the chairman of the hospital board, the very elderly Sir William Phillip. He was perplexed as to whether or not the Alfred really needed a child psychiatrist. His question was, do little children really have mental disorders? I think I was able to assure him that yes, children did experience a range of developmental disorders, anxiety, mood and behavioural disorders, especially the cohort exposed to child abuse and neglect. I suspect that he was primed by the public perception of a psychoanalyst talking to a patient on a couch saying, "Tell me about your problems." And he found it hard to picture that situation for a child. What he would have thought of a baby on the couch is hard to imagine. But however, joking aside, a baby on the couch can tell you a great deal, not so much in word, but in actions. Indicators of developmental delays and disturbances, particularly in emotional responsiveness and reciprocity, tell us a great deal about biological characteristics and psychological achievements like attachment. We can see in tonight's presentation how these assessment processes have been honed over recent decades and how skilled clinicians are able to focus meaningfully on key issues in their understanding of the infant's psychological world and its relevance for treatment. Also, how they're able to communicate these understandings to their trainees. Psychiatrists try hard to arrive at a case formulation of how how the biological, psychological and social aspects of their client set the stage for the observed functioning, account for difficulties and maintain dysfunctional states. Such formulations are the basis for a shared commitment by clients and clinicians for changes to be brought about in the treatment. For all patients, the social factors include relationships with others, especially family members. This is the foundation stone of family therapy approaches to case management. But for children, especially infants, family relationships are absolutely central to their developmental progress. Everyone can see that infants and children will be profoundly affected by parental incapacity through postpartum depression, psychotic illnesses, severe substance abuse, domestic violence, and similar dysfunctions. However, I think what shines through in tonight's oration is how much further this awareness of the impact of relationships has developed. Colouring the relationship between infant and mother is not only the reality of the child rearing circumstances and mother's capabilities, but the ghost in the nursery, the emotional meaning of the child to the mother. It is a major achievement for those ghosts to be exposed and disempowered. The conceptualisation of infant psychiatry as an intervention process within a system identifies it as a super specialty. As such, it enriches our understanding of mental health and well-being for everyone, not only for the infants. So thank you, Campbell, for a great exposition of these themes.
Thank you, Alan, for your insights and for getting our discussion rolling. I now invite people in the audience to make a comment or ask a question of Campbell. There are roving mics for the live audience here. We hope we can respond to you if you're on Zoom as well. Just type into the Q&A section, and our moderator here, Dr. Cecilia Winkleman, can read out your question to Campbell. So is anybody wanting to make a comment?
Thank you for such a great speech, Dr. Paul. I have a couple of questions. The first is that you seem to focus very much on the relationship between the baby and its mother. Like I quote, you say the mother is a playmate and a friend. And I sort of wonder whether that's a sort of very early sort of 20th century concept of motherhood, because there are fathers out there who would love to spend time with their babies, and there are mothers out there who like to have careers. And I just wonder why in particular the baby's bonding with the mother is significance compared with bonding with the father. Thanks.
Very good question. I mean, I tried through my talk to bring the father in as we went. I didn't have the dad actually directly involved in the two clinical cases we talked about, or the three. But in our work at the hospital, fathers are very involved, and we're in a really privileged, lucky position there, because when it's nearly time to go home, you know, that's a good time to go up to the ward, because you're likely to come across a dad there who might not be able to respond and come to a pre-arranged appointment, or has been busy coming to pre-arranged appointments with the surgeon or the physician or the paediatrician. So no, we focus very much on engaging and working with fathers as well as mothers. But also same-sex families, working with both mothers or both fathers, and working with grandparents who are primary carers We had an occasion on the ward a little while ago where one of the grandmothers who was being a primary carer had a really distressing experience, and we were working with her. And if it was her, the baby's grandfather, we'd be doing the same. But it is true that in research, for convenience, people have often focused on babies and mothers and their relationship. In previous generations, statistically, probably that was maybe seemed to be valid, but I think I don't think it really is, because the father, the other partner, the new partner who might not have been around at the time of the birth, are key people in that child's life, and key people as part of the family. At our Congress in WAME in Dublin, we'll have a number of invited symposia about fathers, and actually doing a forward to a book edited by Hiram Fitzgerald and colleagues, which is about this thick. I'm anticipating on work with fathers and infants. So you pick up on a really important topic. Thank you.
Excellent, thank you.
Thanks, Campbell. That was lovely to hear you speak on infant mental health. My question's really about the voice of infants and children's in the system. You're sort of aware that the recent Royal Commission into the Victorian mental health system has really emphasised the need for sort of lived experience voices in all levels of the system. And I guess people seem perplexed how to bring in the voice of infants and young children into having a say in how the system is designed and run. I wonder if you have comments on that.
Yeah, another very good question. Had more fathers involved, that might make a difference too, but that's another. That was a way of saying that it's important for parents to be able to do that, to speak for their own infants and young children. But it can be very hard because they'll have their own set of difficulties or priorities. So, but it means, I think, working with parents where we can, and actually reaching out and advertising. So hopefully this Good Friday that you might see presence of infant mental health, engaging parents and encouraging them to speak for their children. But I think all the research work that we've been talking about is important too, that we can demonstrate to skeptical people that toddlers do have a voice, do have experiences that they can talk about. They can let us know even before they've started with words. One of the things that I often build into a lecture is a talk or a workshop is some of the videos from Tomaselli and the group from Leipzig, where they show the capacity of toddlers to demonstrate empathy. There's a guy who's trying to hang some clothing on the washing line in the laboratory being filmed, and in the corner of the room is a 15-month old child with the mother, new to the situation, no preparation, and the guy's struggling, and he drops the peg and hesitates, and the little toddler walks straight across, picks up the peg and hands it to him. He knows what the guy's trying to do, and he knows he's struggling. Those sort of things, when you combine it with evidence that children who are traumatised or are suffering aren't able to do that, aren't in a place where they can be creative and autonomous, those sort of things can have an impact if we are vocal enough on the people planning things. But it is a problem at the moment. You're working really hard in the office of the chief psychiatrist, but in the health department, they've got a lot of other priorities. And I think, as often happens, very young children fall to the bottom. There was a big summit about early childhood recently in Melbourne, and our college was given, I think, 2 days' notice by way of invitation to attend and participate. So we do need to get out there, and the work you do through the college is really important in that. But yeah, marching up to Spring Street might be another thing that we need to do.
Oh, shall I go next? Thanks. First of all, thank you so much,
No,
Campbell.
sure.
That was just so lovely. And just looking through the eyes, I've got a new granddaughter, so I'm looking at all these sort of things and remembering. Forget, don't you? I just wanted to get your thoughts. So today I was actually at a meeting where they're talking about what's going to be in the next Young Minds Matter survey. So this is a survey that was now done 10 years ago that really looked at mental health disorders, but only started at age 4. And they're talking about starting younger. And you'll be pleased to know I put a big plea in for including parents in the survey, because at the moment there's nothing about parents, which is a bit crazy in my view. But what are your thoughts in terms of how you balance the kind of obviously clinical needs of these infants, but actually, to your previous point, against the kind of population needs of these infants without really truly understanding the prevalence of these disorders? I know you're saying it's the same, but actually we don't have any data in Australia to help us know that. And of course, the tricky thing of actually measuring this stuff.
Yeah, well, there are tools. The Promise, which you'll know about, is a parent administered, or parent. They respond to it. It's a questionnaire, and it's been adapted to include infants and babies. And colleagues in Brisbane at their perinatal and infant mental health statewide program have been using that, particularly through COVID. And that looks like a promising tool. It's free and available, and seems to have good validity. But there are others, as you know, the ASQ and things like that. But to get to the very young ones is with reliability and validity is harder. The ADBB that I mentioned has been used with clinical populations in particular, but I don't know how that would go. I don't think it'd be a community survey tool. It's something it's an observational tool, so it makes it more expensive, and it's also something that changes depending on the context. So it's a really useful clinical tool, but there are others. The Danes have just published a paper a few months ago about a community survey that they're doing using their own parent-administered tool, a bit like the bits here, but going back into the first year of life. So there are tools there, but they have to be cheap and usable to go into a big survey like that, and be happy to have some more chats. Thanks, Rachel. And then there's about what do you do when you find out, and how do you reach them, the mass of children in need, and programs like yours, Right at Home, and others like that are really important, and that's where we need to be as psychiatrists, collaborating and working with paediatricians, which I didn't emphasise enough in my talk today, but another time. Yeah, Maury.
Thank you, Campbell. Thank you so much again, Campbell, over many years of contribution. And as a very famous person here might say, it was a tour de force, the way you went from bust to dust. starting with the bust. But I was going to ask you, I remember when Dr. Rickards returned from Dakar, from Senegal, from the international study groups. Did I do that? When he returned from those international study groups, were organized in the Yakapap's early days before there was an A in the Yakapap. And he was so excited to discover principles about infants and children from around the world, from Africa and from Asia. And he brought these back to the department with great excitement. And the department became a kind of laboratory for understanding the infant and the child at a global level. And it was so nice to hear in your introduction your reference to Indigenous work and your own work in that area. I was so interested to find out how that strand coalesced with Dr. Rickards' strand from the 1960s and the 70s on diversity, and how the studies that you emphasized from the United Kingdom, from the United States, from Canada, from Australia, captured a certain spectrum of that. Yeah. But could you tell us a little bit more about the way in which the work of the RCH that you lead could be a laboratory, a living laboratory of diversity? And have you got in your presentation, in the next oration that you'll give, a kind of blueprint for, let's call it, a theory of the infant mind that incorporates diversity?
Yeah, another really important and good question. I'm going to come again. This is we don't have to go far for diversity at the hospital. I haven't seen the recent breakdown of figures, but I think it represents probably a more diverse, well, I'm sure it does, a more diverse population than you might find in North Fitzroy or somewhere like that in the hospital. In the hospital population. If I went through in my mind the families that I've been with today, with a mother with a child with cancer who's a Syrian refugee, families from the Indian subcontinent, especially through COVID, where families had previously parents, aunties coming out to spend time with the family around the birth of a baby, and the time after that for 2 years that didn't happen, and you had couples who were really struggling and putting pressure on the couple relationship and family violence and stress, but bringing their family culture and approaches to infant and childcare as well. But certainly with WAME, we are trying to reach out and connect with as many cultural groups as we can and communities around the world. Our NBO training today, we had 2 people from Manila. We had another person from the Pacific, and we had quite a few Kiwis as well. Not so much major cultural diversity there, but there were certainly First Nations people from both New Zealand, some pretty strong ones, and from Australia as well in our training group of 25. So it's interesting, COVID has certainly opened up access to things like that. We've done the NBO training with groups in Manila, in Thailand, in Hong Kong, in China, but not in Kampuchea yet. And I know you had a major contribution to understanding refugees, particularly unaccompanied young people who were landing on our shores, and that was something that was really important, and one of the things I think that Winston encouraged as well. And there are a lot of studies looking at cross-cultural aspects of infant care, but it's very complicated now because people are moving around a lot. With our infant mental health and NBO training, we've been very privileged to be able to spend time in Johannesburg. There's a group providing mental health services and psychotherapy to Alexandra, which is what is it, about 600,000 or 700,000 people in the middle of Joburg living in a shanty town. And it was really certainly very helpful learning for us, but we were able to share things like the NBO and approaches to psychotherapy delivered by women who left school at high school, beginning of high school, who were able to come into a training program and learn skills that were able to be culturally consonant. And they were working with a multicultural group as well. That group of people living in the middle of Joburg are from all over Africa. There's another program based on the Ambience, which is a tool to look at how traumatized mothers respond when a toddler is distressed. So it's like the flip side of the strange situation, and you're really observing the parent's response to a child's distress. And they've been able to use this tool to train community workers in Canada to work with the most difficult traumatized families in quite a productive way. They're able to have their workers observe and understand what the parent's behaviour means when they're unresponsive or frightening or threatening to their toddler. And this tool has been able to be grasped and used by people without primary mental health training. So I think that comes back to Rachel's question about how we extend the learnings and understandings that we have and learn from our colleagues in early childhood, in childcare, in family support agencies. We need to work closely with them at the grassroots as well. And that'll get us, certainly in this country, to a broad cultural experience as well.
Good evening, Anne McLeish from Grandparents Victoria and Kinship Carers Victoria. I want to give you some unsolicited advice.
You can, welcome to do that. I know you're good at.
You mentioned the need for you to work more closely with paediatricians. I'm here to ask you to work more closely with the department and the government as a whole. You said that you're prepared to perhaps march on Spring Street. I invite you to do that as well. On this issue, on the issue of therapeutic play, in child protection services, there are so many thousands of children who are never going to get the benefit of the sort of program that you offer at the Children's Hospital, but who are nevertheless dealing with trauma. And we think that in the absence of a lot of other services like access to psychologists, which we just can't get for them, that therapeutic play has got to be a basic standby for all of these children. And we are working with associations like the International Play Association, Play Australia, Play Victoria, to try and get some sort of statewide program that introduces the best elements of therapeutic play into every play situation in the home, in kindergartens.
Absolutely. I couldn't agree more. I think in our community teams, the infants that we're seeing, the figure is something like 50% are ones where child protection are involved, but it's only a drop in the bucket of those children who need intervention and families who need intervention and support. We're working with a group to see if we can have more children's courts which are family friendly, adapting the model of the Broadmeadows Drug and Alcohol Court, and we're pushing very hard for that at the moment too. Got colleagues at Tweddle and other organisations who are trying to see change happen there and move away from the rigid adversarial sometimes stalemate that happens in the children's court.
Thank you. Thank you, Campbell. This discussion could go on for a very long time. We know that. Thank you very much. But we do need to approach our finale now, and I'd like you to keep your seat for the MIFIC president, Professor Joe Grimwade, to speak briefly and bring our evening to a conclusion. Yes, you speak, please.
Okay, this comment comes from Fiona Mensa. She says, she writes, "Thank you, Associate Professor Paul and Dr. Maudsley. I really appreciate your wisdom and such inspiring insights into the little ones at RCH and in the communities we work with. I agree there couldn't be more importance than to understand and support families in this way. So delighted you are working with Kath with healing the past to nurture the future. I've been privileged to work with her as a statistician. Thank you again, and with all good wishes, Fiona."
Thank you, Fiona. Thank you.
Yeah. Good evening, everybody, and thank you for coming along. We had 120 odd people on the list, and we haven't got quite as many as those people turned up, but I hope that means that there might be 60 or 70 people somewhere around the world and in their homes talking with us. We like to bring this to you every year, and I've got a special gift for Campbell for his effort. Here's a card.
Thank you very much.
And I think you're well read. Appreciate it. Thank you very much. MIFIC tries to do lots and lots of things. And the things that we would like to do, we want to do a lot more of, but we need other people to help us. We are a committee of about 6 people. Some of us are still working. I'm the youngest member. We would like to be able to invite others to join us on the committee. And we would like some of those people who are out there in Zoom land to join us and be part of this organisation and pay $50 to be a member, and maybe pay us time through contribution to the committee. This sort of event happens because people like Alan and like Winston established a lineage of people who think that the most important thing we can do for children is to help children have a good start in life. The most important thing we can do for families. And now Winston started the department, the psychiatry department of the children's in 1955. That was the year that I was born. So we stand in his shadow, we stand on his shoulders, and Campbell clearly does that, and we can only honour him over and over again. But the best way to honour Winston and the best way to honour Campbell is to stump up your $50, please. So that's us. We do. I hope people do actually explore the MIFIC website. There's a lot of stuff there, and a lot of stuff about what can be done, interventions for professionals, and engagement for community members to find out about how you can help your families do better. We're going to have, as we finish, we're going to have a photo session. Please don't come up to the front and try and talk with Campbell. Campbell will be available outside in the foyer afterwards. We're going to have some photos of the presenters and the Rickards family. They are living treasures of a man who was a treasure, and we stand in his stead and in honour of him. It's a great privilege. Thank you, Campbell, I really liked something that happened in your talk, which was missing. You hardly ever said anything about attachment, and I was going, hooray. So, thank you, everybody.